Here are the next 20 questions and answers, continuing from Serpent Nasi 214. 214. Why is intravenous vancomycin not used for antibiotic-associated diarrhea? IV vancomycin cannot reach the intestines in high enough concentrations to treat C. difficile. 215. Why has the treatment of C. difficile changed from metronidazole to vancomycin or fidaxomicin? Vancomycin and fidaxomicin are more effective than metronidazole. 216. When should vancomycin be chosen over fidaxomicin? Vancomycin is chosen over fidaxomicin because it is less expensive. 217. What should be done if C. difficile recurs after vancomycin treatment? Try a tapered dose of vancomycin or switch to fidaxomicin. 218. What is the treatment for multiple recurrences of C. difficile? For multiple recurrences, the treatment is fecal transplantation. 219. What is fulminant C. difficile infection? Fulminant C. difficile is a severe, life-threatening infection with high WBC, acidosis, high lactate, and high creatinine. 220. How is fulminant C. difficile treated? Both vancomycin and metronidazole should be used together to treat fulminant C. difficile. 221. What is the key tip for treating C. difficile if vancomycin is not effective? Switching to fidaxomicin is the answer when vancomycin doesn't work. 222. What is celiac disease? Celiac disease is an autoimmune disorder where the body reacts to gluten, damaging the small intestine. 223. What are other conditions that can present similarly to celiac disease? Chronic pancreatitis, tropical sprue, and Whipple disease can also cause fat malabsorption. 224. What is steatorrhea? Steatorrhea refers to oily, greasy, floating, and foul-smelling stools due to fat malabsorption. 225. What types of vitamins are affected by fat malabsorption? Fat malabsorption leads to deficiencies in fat-soluble vitamins A, D, E, and K. 226. What are the symptoms of vitamin D deficiency? Vitamin D deficiency can cause hypocalcemia and osteoporosis. 27. What are the symptoms of vitamin K deficiency? Vitamin K deficiency can cause bleeding and easy bruising. 228. What are the symptoms of vitamin B12 deficiency? Vitamin B12 deficiency can cause anemia, hypersegmented neutrophils, and neuropathy. 229. How does fat malabsorption affect weight? Fat malabsorption often leads to weight loss due to insufficient calorie and nutrient absorption. 230. What is unique about vitamin B12 absorption? Vitamin B12 requires an intact bowel wall and pancreatic enzymes to be absorbed. 231. How can celiac disease and tropical sprue be distinguished clinically? Celiac disease and tropical sprue have no clear clinical distinction based on symptoms alone. Here are the next 20 questions and answers. 232. What additional symptom may be seen in celiac disease? Dermatitis herpetiformis, a skin rash, is seen in about 10% of people with celiac disease. 233. What are some key symptoms of Whipple disease? Whipple disease can present with arthralgias, ocular findings, neurologic abnormalities, fever, and lymphadenopathy. 234. What is the treatment for Whipple disease? Whipple disease is treated with ceftriaxone, followed by TMP-SMX. 235. How does chronic pancreatitis differ from celiac disease in terms of malabsorption? Chronic pancreatitis often causes iron deficiency, unlike celiac disease. 236. What is the first test for diagnosing celiac disease? The first test is the anti-tissue transglutaminase, TTG, antibody test. 237. What are other tests for celiac disease? Other tests include anti-endomysial antibody, IgA anti-gliadin antibody, and small bowel biopsy. 238. What is the role of a small bowel biopsy in diagnosing celiac disease? Biopsy shows flattening of the villi. a characteristic sign of celiac disease. 239. Why is a bowel biopsy essential in celiac disease diagnosis? Biopsy helps rule out conditions like lymphoma that can also damage the small intestine. 240. How are Whipple disease and tropical sprue diagnosed? They are diagnosed by bowel wall biopsy showing the specific organism. 241. What is the role of abdominal X-ray in diagnosing pancreatic conditions? Abdominal X-ray is 50 to 60% sensitive for detecting pancreatic calcification. 242. How accurate is an abdominal CT scan in detecting pancreatic calcification? Abdominal CT scan is 80 to 90% sensitive for detecting pancreatic calcification. 243. What is secretin stimulation testing and why is it important? Secretin stimulation is the most accurate test for pancreatic function, measuring bicarbonate-rich fluid release. 244. What does an abdominal X-ray indicate for chronic pancreatitis? Abnormal X-ray results are very specific for chronic pancreatitis. 245. What dietary changes are recommended for celiac disease? Patients should avoid gluten-containing foods like wheat, oats, rye, or barley. 246. What is the treatment for chronic pancreatitis? The treatment includes enzyme replacement therapy. 247. How is Whipple disease treated? Whipple disease is treated with ceftriaxone followed by TMP-SMX. 248. What is the treatment for tropical sprue? Tropical sprue is treated with TMP-SMX and tetracycline. 249. What is the purpose of the Deeg-Xylose test? The Deeg-Xylose test was used to distinguish pancreatitis from bowel wall abnormalities. 250. What is carcinoid syndrome? Carcinoid syndrome presents with intermittent diarrhea, flushing, wheezing, and right-sided heart abnormalities. Here are the next 20 questions and answers. 232. What additional symptom may be seen in celiac disease? Dermatitis herpetiformis, a skin rash, is seen in about 10% of people with celiac disease. 233. What are some key symptoms of Whipple disease? Whipple disease can present with arthralgias, ocular findings, neurologic abnormalities, fever, and lymphadenopathy. 234. What is the treatment for Whipple disease? Whipple disease is treated with ceftriaxone, followed by TMP-SMX. 235. How does chronic pancreatitis differ from celiac disease in terms of malabsorption? Chronic pancreatitis often causes iron deficiency, unlike celiac disease. 236. What is the first test for diagnosing celiac disease? The first test is the anti-tissue transglutaminase, TTG, antibody test. 237. What are other tests for celiac disease? Other tests include anti-endomysial antibody, IgA anti-gliadin antibody, and small bowel biopsy. 238. What is the role of a small bowel biopsy in diagnosing celiac disease? Biopsy shows flattening of the villi, a characteristic sign of celiac disease. 239. Why is a bowel biopsy essential in celiac disease diagnosis? Biopsy helps rule out conditions like lymphoma that can also damage the small intestine. 240. How are Whipple disease and tropical sprue diagnosed? They are diagnosed by bowel wall biopsy showing the specific organism. 241. What is the role of abdominal X-ray in diagnosing pancreatic conditions? Abdominal X-ray is 50 to 60% sensitive for detecting pancreatic calcification. 242. How accurate is an abdominal CT scan in detecting pancreatic calcification? Abdominal CT scan is 80 to 90% sensitive for detecting pancreatic calcification. 243. What is secretin stimulation testing and why is it important? Secretin stimulation is the most accurate test for pancreatic function, measuring bicarbonate-rich fluid release. 244. What does an abdominal X-ray indicate for chronic pancreatitis? Abnormal X-ray results are very specific for chronic pancreatitis. 245. What dietary changes are recommended for celiac disease? Patients should avoid gluten-containing foods like wheat, oats, rye, or barley. 246. What is the treatment for chronic pancreatitis? The treatment includes enzyme replacement therapy. 247. How is Whipple disease treated? Whipple disease is treated with ceftriaxone followed by TMP-SMX. 248. What is the treatment for tropical sprue? Tropical sprue is treated with TMP-SMX and tetracycline. 249. What is the purpose of the Deeg-Xylose test? The Deeg-Xylose test was used to distinguish pancreatitis from bowel wall abnormalities. 250. What is carcinoid syndrome? Carcinoid syndrome presents with intermittent diarrhea, flushing, wheezing, and right-sided heart abnormalities. Here are the next 20 questions and answers. 271. What is inflammatory bowel disease? IBD. IBD is an idiopathic disorder that causes diarrhea, blood in stool, weight loss, and fever. 272. What are the two main types of IBD? The two main types are Crohn's disease, CD, and ulcerative colitis, UC. 273. What are the extraintestinal manifestations of IBD? Extraintestinal manifestations include arthralgias, uveitis, skin conditions, and sclerosing cholangitis. 274. What is erythema nodosum and what does it indicate in IBD? Erythema nodosum is a skin condition that indicates active disease in IBD. 275. Does IBD increase the risk of colon cancer? Yes, both CD and UC can increase the risk of colon cancer if the colon is involved long term. 276. What is the difference between Crohn's disease and ulcerative colitis? CD can affect any part of the GI tract and has transmural lesions, while UC only affects the colon and has mucosal lesions. 277. When should screening for colon cancer occur in IBD patients? Screening should begin after 8 to 10 years of colonic involvement and be done every 1 to 2 years. 278. What are the most accurate diagnostic tests for IBD? Endoscopy is the most accurate, and barium studies are useful for Crohn's affecting the small bowel. 279. What blood tests are helpful in diagnosing Crohn's disease and ulcerative colitis? ANCA is positive in UC and negative in CD, while ASCA is positive in CD and negative in UC. 280. How is IBD treated during an acute flare-up? During a flare, IBD is treated with steroids to reduce inflammation. 281. What is used to maintain remission in IBD? 5-ASA derivatives like mesalamine are used to maintain remission. 282. What are anti-TNF medications and when are they used in IBD? Anti-TNF drugs like adalimumab and infliximab are used for severe or refractory IBD. 283. What is vedolizumab and when is it used in IBD treatment? Vedolizumab is used when other treatments like anti-TNF drugs don't work. 284. What is the role of budesonide in IBD treatment? Budesonide is a steroid with minimal systemic effects, making it ideal for IBD. 285. How is perianal Crohn's disease treated? Perianal Crohn's disease is treated with ciprofloxacin and metronidazole. 286. When is surgery required for IBD? UC may require colectomy, which can cure the disease. Crohn's often recurs after surgery. 287. What is short bowel syndrome? SBS. SBS occurs when at least half of the small intestine is removed, often due to Crohn's disease. 288. What are the common symptoms of SBS? Patients with SBS often experience diarrhea, dehydration, malnutrition, weight loss, and steatorrhea. 289. Why does short bowel syndrome cause malnutrition and vitamin deficiencies? SBS leads to deficiencies in vitamins A, D, E, K, B12, as well as minerals like calcium, magnesium, iron, and zinc, because the shortened intestine cannot properly absorb nutrients. Here are the next 20 questions and answers. 290. How is short bowel syndrome treated? Treatment includes a low-fat diet, intravenous hyperalimentation, IV nutrition, loperamide for diarrhea, teduglutide to improve absorption, and vitamin supplementation. 291. What is small intestine bacterial overgrowth? SIBO. SIBO occurs when bacteria that normally live in the large intestine start growing in the small intestine, often after the ileocecal valve is lost. 292. What symptoms do patients with SIBO experience? Patients with SIBO have symptoms like flatulence, bloating, diarrhea, and steatorrhea, fatty stools. 293. How is small intestine bacterial overgrowth, SIBO, diagnosed? SIBO is diagnosed by taking a small bowel aspirate and culturing it to check for abnormal bacterial growth. 294. What is the treatment for small intestine bacterial overgrowth, SIBO? The first-line treatment for SIBO is antibiotics, with rifaximin being the preferred choice. 295. What is microscopic colitis? Microscopic colitis is a type of chronic diarrhea that doesn't show abnormalities during colonoscopy, but is detectable under a microscope through biopsy. 296. What are the types of microscopic colitis? The main types are lymphocytic colitis, collagenous colitis, and mastocytic colitis. 297. How is microscopic colitis treated? Microscopic colitis is typically treated with steroids to reduce inflammation in the colon. 298. What is a clue to the diagnosis of microscopic colitis? A history of autoimmune disease in the patient can suggest microscopic colitis. 299. What is diverticulosis? Diverticulosis refers to the presence of outpocketings or small sacs in the colon, especially common in people over 65 and 70 years old. 300. Why do vegetarians rarely develop diverticulosis? Vegetarians are less likely to develop diverticulosis because their high-fiber diet helps prevent the formation of diverticula. 301. Is diverticulosis always symptomatic? No. Diverticulosis is asymptomatic most of the time. 302. What symptoms may indicate diverticulosis? Diverticulosis can cause left lower quadrant abdominal pain, constipation, bleeding, and infection. Diverticulitis. 303. What is the most accurate test for diverticulosis? The most accurate test is colonoscopy. 304. How can diverticulosis be prevented or treated? Increasing dietary fiber can help prevent complications of diverticulosis. 305. What is diverticulitis? Diverticulitis occurs when one or more of the diverticula become infected or inflamed, leading to more severe symptoms. 306. What are the symptoms of diverticulitis? Diverticulitis causes left lower quadrant pain and tenderness, fever, and leukocytosis. 307. Why are colonoscopy and barium enema dangerous in acute diverticulitis? They can increase the risk of perforation when the colon wall is weakened by infection. 308. What is the best initial test for diverticulitis? The best initial test is a CT scan. 309. How is diverticulitis treated? Diverticulitis is treated with antibiotics targeting bacteria like E. coli and anaerobes. Here are the next 20 questions and answers. 310. Should patients with acute diverticulitis be fed? No, patients should not be fed during the initial phase to allow the inflamed colon to rest and recover. 311. What is the role of surgery in diverticulitis? Surgery may be necessary for no response to antibiotics, frequent recurrences, or complications like perforation. 312. Who is more likely to need surgery for diverticulitis, younger or older patients? Younger patients are more likely to need surgery due to more recurrent episodes over their lifetime. 313. Can diverticulosis be fully cured? No, diverticulosis cannot be fully cured, as the pouches in the colon remain even after treatment. 314. Does fiber in the diet help with diverticular disease? Yes, a high-fiber diet can help reduce the risk of complications from diverticulosis and prevent diverticulitis flare-ups. 315. What is the problem with using sigmoidoscopy for colon cancer detection? Sigmoidoscopy cannot detect lesions proximal to the rectum and sigmoid colon, which account for 40% of colon cancers. 316. What are the limitations of other screening tests for colon cancer? Barium studies, CT colonoscopy, and capsule endoscopy can't perform biopsies, and FOBT has more false positives and negatives. 317. Why is a positive FOBT followed by a colonoscopy? A positive FOBT suggests bleeding, but colonoscopy is needed to identify the source, whether it's cancer or another condition. 318. Why is virtual colonoscopy never the correct answer for colon cancer screening? Virtual colonoscopy cannot perform biopsies and may miss small or flat lesions detectable by traditional colonoscopy. 319. What is capsule endoscopy used for? Capsule endoscopy is used to detect sources of bleeding in the small bowel, an area inaccessible to traditional endoscopy. 320. How often should adults undergo colonoscopy for routine screening? Adults should have a colonoscopy every 10 years starting at age 50. 321. When should colon cancer screening begin for someone with a family history? If a single family member had colon cancer, screening should begin 10 years earlier than their age at diagnosis or at age 40, whichever is younger. 322. What is hereditary non-polyposis colon cancer, HNPCC? HNPCC, or Lynch syndrome, is characterized by colon cancer in multiple family members across 2 generations, often before age 50. 323. What is familial adenomatous polyposis, FAP? FAP is a condition where a person develops thousands of polyps in the colon due to a mutation in the APC gene. 324. What is the recommended screening for FAP? For FAP, screening starts with sigmoidoscopy at age 12 every year. 325. What is Peutz-Jeghers syndrome? Peutz-Jeghers syndrome is characterized by hamartomatous polyps in the colon and melanotic spots on the lips and skin. Here are the next 20 questions and answers. 326. When should screening begin for Peutz-Jeghers syndrome? Screening for Peutz-Jeghers syndrome should start at age 8, with colonoscopy every 3 years. 327. What is Gardner syndrome? Gardner syndrome is characterized by colon cancer, along with osteomas, desmoid tumors, and other soft tissue tumors. 328. When should screening start for Gardner syndrome? Screening for Gardner syndrome should start at age 12 with yearly sigmoidoscopy, similar to FAP. 329. What is Turcot syndrome? Turcot syndrome is a condition where colon cancer occurs in association with central nervous system malignancies like brain tumors. 330. How does juvenile polyposis relate to colon cancer? Juvenile polyposis involves the development of multiple hamartomatous polyps in children, increasing colon cancer risk. 331. What anticoagulation precautions should be taken before colonoscopy? NOACs should be stopped 1 day before, and warfarin 3 to 5 days before, especially for patients with mechanical heart valves. 332. What is acute pancreatitis? Acute pancreatitis is the sudden inflammation of the pancreas, often caused by alcohol or gallstones. 333. What are the main causes of acute pancreatitis? Over 90% of cases are caused by alcoholism or cholelithiasis, gallstones. 334. How does cholelithiasis cause acute pancreatitis? Gallstones can block the ducts that carry digestive enzymes from the pancreas, causing inflammation. 335. How does alcohol cause acute pancreatitis? excessive alcohol consumption can repeatedly damage and inflame the pancreas, eventually leading to acute pancreatitis. 336. What are some less common causes of acute pancreatitis? Less common causes include trauma, hypertriglyceridemia, hypercalcemia, infections, and certain medications or drugs. 337. How does trauma lead to acute pancreatitis? Injury to the pancreas, such as from an accident, can cause inflammation and acute pancreatitis. 338. How does hypertriglyceridemia cause acute pancreatitis? Very high levels of triglycerides in the blood can trigger inflammation in the pancreas. 339. How does hypercalcemia contribute to acute pancreatitis? Excess calcium can damage pancreatic cells, leading to inflammation and acute pancreatitis. 340. Can infections cause acute pancreatitis? Yes. Viral infections like mumps or hepatitis can lead to acute pancreatitis by infecting the pancreas. Here are the next 20 questions and answers. 341. How can drug toxicity cause acute pancreatitis? Certain drugs like pentamidine, didenosine, azathioprine, and estrogens can damage the pancreas, causing inflammation. 342. How do drug allergies contribute to acute pancreatitis? Drug allergies, such as to sulfa drugs, can trigger an immune response that inflames the pancreas. 343. How does ductal obstruction cause acute pancreatitis? Blockage of the pancreatic duct by a gallstone or tumor prevents enzymes from flowing into the intestine, leading to pancreatitis. 344. Can cystic fibrosis lead to acute pancreatitis? Yes, the mucus buildup in cystic fibrosis can block the pancreatic ducts, causing inflammation. 345. How can a scorpion sting cause acute pancreatitis? Some scorpion venoms can directly trigger inflammation in the pancreas. 346. What is the relationship between trauma, ductal obstruction, and pancreatitis? Both trauma and ductal obstruction can prevent normal enzyme flow, causing the enzymes to damage the pancreas. 347. What happens when severe pancreatic damage occurs? Severe damage decreases lipase production, leading to fat malabsorption. 348. How does pancreatic damage affect calcium absorption? Unabsorbed fat binds to calcium, causing calcium malabsorption. 349. Are elevated amylase and lipase levels always a sign of severe pancreatitis? No. There's no direct correlation between enzyme levels and disease severity. 350. Does pain intensity correlate with the degree of organ damage in pancreatitis? No. Pain intensity is subjective and does not match the actual pancreatic damage. 351. Does CRP correlate with disease severity in pancreatitis? No. CRP levels do not reliably indicate pancreatitis severity. 352. What is the best initial test to diagnose pancreatitis? The best initial tests are amylase and lipase. 353. What is the most specific test for pancreatitis? The most specific test is a CT scan. 354. How does disease severity correlate with CT scans? Severity strongly correlates with the degree of pancreatic necrosis seen on CT. 355. When is a needle biopsy necessary in pancreatitis? A needle biopsy is used to check for infection if there is extensive pancreatic necrosis. Here are the next 20 questions and answers. 356. What are some laboratory findings in pancreatitis? Common findings include leukocytosis, drop in hematocrit, elevated LDH and AST, hypoxia, hypocalcemia, and elevated urinary trypsinogen. 357. What is the best imaging test for pancreatitis? The best imaging tests are CT scan and MRI. 358. What is MRCP used for in pancreatitis? MRCP is useful for finding the cause of pancreatitis, such as stones, strictures, or tumors. 359. What is the role of plain X-ray in pancreatitis? Plain X-ray may show a sentinel loop of bowel, but it is not a definitive test. 360. Why is ultrasound not very useful in pancreatitis? Ultrasound has poor accuracy because the bowel often blocks the view of the pancreas. 3 and 61. How is an abdominal CT scan performed for pancreatitis? It is always done with both IV and oral contrast to better visualize the abdomen. 362. What is the initial treatment for pancreatitis? Initial treatment includes NPO, IV fluids, analgesia, and proton pump inhibitors. 363. When are antibiotics used in pancreatitis? Antibiotics are given if there is more than 30% pancreatic necrosis to prevent infection. 364. How is infected necrotic pancreatitis treated? Surgical debridement is required to remove dead tissue and prevent complications. 365. How are pseudocysts treated in pancreatitis? Enlarging or painful pseudocysts are drained with a needle. 366. What is the role of ERCP in pancreatitis treatment? ERCP is used to remove obstructing stones, dilate strictures, and place stents to improve bile and pancreatic flow. 367. What is IgG4-related pancreatitis? IgG4-related pancreatitis is an autoimmune condition characterized by elevated IG4 levels and enlarged sausage-shaped pancreas. 368. What does the CT scan show in IG4-related pancreatitis? The CT scan shows an enlarged sausage-shaped pancreas. 369. How is the diagnosis of IgG4-related pancreatitis made? Diagnosis requires elevated serum IgG4 levels and the absence of significant alcohol intake or stones. 370. What is the key to distinguishing IgG4-related pancreatitis from other conditions? The key is the absence of significant alcohol use or stones, which are common in other types of pancreatitis. Here are the next 20 questions and answers. 371. What is the characteristic feature seen on a biopsy for IgG4-related pancreatitis? A biopsy shows lymphocytic and plasma cell infiltrates. 372. Why is autoimmune pancreatitis often confused with pancreatic cancer? Autoimmune pancreatitis can look very similar to pancreatic cancer on imaging. 373. What are the symptoms of pancreatic cancer? Pancreatic cancer presents with painless jaundice, weight loss, and a non-tender epigastric area. 374. How do amylase and lipase levels change in pancreatic cancer? In pancreatic cancer, amylase and lipase are typically normal, while bilirubin, alkaline phosphatase, and GGTP are elevated. 375. How is pancreatic cancer diagnosed? A CT scan detects a pancreatic mass in 90% of cases. 376. What happens if a CT scan is negative for pancreatic cancer? If CT is negative, the next step is an endoscopic ultrasound with biopsy. 377. What is the prognosis for pancreatic cancer? The 5-year survival rate for pancreatic cancer is only 5%. 378. How effective are chemotherapy and radiation in treating pancreatic cancer? Chemotherapy and radiation have little benefit in treating pancreatic cancer. 379. What are cystic neoplasms of the pancreas? Cystic neoplasms are cysts that have a small chance of turning into pancreatic cancer over time. 380. What types of cystic neoplasms are associated with pancreatic cancer? Mucinous cystadenomas and intraductal papillary mucinous neoplasms are associated with elevated CEA and CA19-9. 381. Why must cystic neoplasms of the pancreas be removed? They must be removed to prevent them from becoming invasive cancer. 382. What is the malignant potential of cystic neoplasms? The malignant potential ranges from 0 to 70%. 383. What is ascites, and how is it related to liver disease? Ascites is fluid buildup in the abdomen, commonly caused by portal hypertension due to cirrhosis. 384. When should paracentesis be performed in ascites? Paracentesis should be done for new onset ascites, abdominal pain, tenderness, or fever. 385. What is the serum ascites albumin gradient? SAIG, and what does it indicate? SAIG 1.1G-DL suggests portal hypertension, while SAIG 1.1G-DL suggests other causes,